Hello, dear doctors, nurses, medical students, and healthcare team. How are you today? I hope you are well today, saving lives. Here we are going to talk about another question of cardiology. A 60-year-old man with a history of ischemic heart disease starts having chest pain. He has a heart rate of 170 beats per minute and a blood pressure of 70 on 45 mm Hg. An ECG reveals a broad complex tachycardia with the absence of atrial activity. He feels unwell and is now semi-conscious. What is the single most likely diagnosis? A. Stokes-Adams syndrome. B. Ventricular fibrillation. C. Ventricular tachycardia. D. Complete heart block. And E. Atrial fibrillation. According to the sign and symptom, history of ischemic heart disease and chest pain and increased heart rate 170 beats per minute and unstable blood pressure which is 70 on 45 mm Hg with ECG showing broad complex tachycardia, the most likely diagnosis is ventricular tachycardia. Here we are going to explain it. The ECG relieving a broad complex tachycardia with absence of atrial activity in a conscious person can only be ventricular tachycardia. If the patient is unconscious, it's ventricular fibrillation. But when the patient is conscious, we can say that it's ventricular tachycardia. The hypotension seen here supports this. Cardiac arrhythmias are more common in patients with ischemic heart disease, hence the given history. Occasionally in the exam, they may include a picture of an ECG showing a broad complex tachycardia. Again, pick ventricular tachycardia if the patient is still awake, as it is impossible to see a ventricular fibrillation in an awake patient, as I said above. Ventricular tachycardia, okay. Ventricular tachycardia may impair cardiac output with consequent hypotension, collapse, and acute cardiac failure. This is due to extreme heart rates and a lack of coordinated atrial contraction or loss of atrial kick. The rate of ventricular tachycardia is from about 100 to 250 beats per minute. P waves may be present or absent. P waves are usually not seen if the rate is increased. If present, the P waves have no relation to the QRS complex of their ventricular tachycardia. As we can see in this ECG, we have a broad complex tachycardia and we cannot see any P waves, any regular P waves. We can say that these can be P waves, but there is no any relation between P waves and QRS complexes. Okay, ventricular tachycardia can present in two ways. First, with pulse and hemodynamically stable or hemodynamically unstable. Example, the patient has hypotension, chest pain, cardiac failure, and decreased conscious level, as we can see in our patient. And without pulse, the management of ventricular tachycardia depends on how the patient presents. If the patient has pulse and is hemodynamically stable, antiarrhythmics like amiodarone or lidocaine or procainamide is the choice of treatment. But if the patient is hemodynamically unstable, example, the patient has hypotension, chest pain, cardiac failure, decreased conscious level, and the first choice is immediate electrical cardioversion. But in the first step, we cannot detect any pulse for the patient, or as we can say, it's without pulse. Immediate electrical cardioversion is indicated. Here was a short explanation about the patient coming with unstable vital signs and broad complex tachycardia. As we said in the history of this patient, we explain about the broad complex tachycardia and unstable patients in our YouTube videos. For more information, you can watch them. Thank you for your attention.